There are, and I think they differ by class. So, for example, the cereblon inhibitors like lenalidomide are associated with thrombosis. So we assess patients' baseline thrombosis risk and then uh, give them medication to prevent thromboses. Most of the time it's aspirin. Sometimes it's blood thinners, depending on whether they have prior thromboses in the past and how high the risk is. As far as the BTK inhibitors like zanubrutinib, most commonly we worry about bleeding, irregular heart rhythms, and low blood counts. So the low blood counts are pretty easy to manage. We can give growth factors and put patients on prophylactic medications to prevent infections. For bleeding, we monitor closely. In patients that have severe bleeding episodes, we may decrease the dose or stop the medication and switch to a different treatment. And for patients who have irregular heartbeats at baseline, there's studies that suggest that ibrutinib is still well tolerated, so we usually give it a try. And if we can manage any irregular heartbeat as they go through, then we can keep them on the medication. But if it becomes severe, then we take them off. The main factors, since most of them are really well tolerated, to be honest, is whether patients have any of the baseline toxicities or any of the toxicities associated with that drug therapy at baseline. So for example, patients who have poorly controlled atrial fibrillation probably wouldn't be the best candidate for a BTK inhibitor, or if they have history of severe bleeding episodes, again, probably not the best choice. And then patients who've had multiple thromboses in the past or stroke in the past, lenalidomide may not be the best option for them.